All right, let's jump right into this rapid-fire explainer on surgical acid base and metabolic management. No fluff, just the cases. Let's go. Question 37. We've got a patient with labored breathing and a tension hematoma right after a thyroidectomy. Looking at the options, boom, the clear culprit is answer A, respiratory acidosis. Think about it. A post-operative tension hematoma is literally causing direct mechanical compression right over the trachea. This acute upper airway obstruction makes the work of breathing skyrocket. The patient gets exhausted, hypoventilates, and because the lungs just can't clear that carbon dioxide, it builds up in the blood and tanks the systemic pH. Now, for your clinical priority exam pearl, this is a massive surgical emergency. Don't wait for the OR. You need to open that surgical wound right at the bedside, evacuate the clot, and relieve that airway compression instantly.
Moving straight on to question 38, we're looking at the first-line treatment for metabolic alkalosis. Now, don't jump the gun with extreme measures like dialysis. The most effective go-to first-line intervention is A, intravenous saline and potassium chloride. See, the vast majority of metabolic alkalosis cases we see in surgical patients are chloride responsive. Usually they've lost a ton of gastric hydrochloric acid from vomiting or excessive NG suctioning. That depletion causes hypovolemia and hypochloremia. So the renal tubules kind of panic and conserve sodium, but they do it at the expense of kicking out hydrogen ions. By giving IV normal saline with potassium chloride, we restore that intravascular volume, fix the chloride deficit, and basically tell the kidneys to stop retaining bicarbonate. Oh, and here's the pearl. Keep a close eye on that pH. If it crosses the 7.60 threshold, that's when things get serious and you escalate to IV hydrochloric acid, ammonium chloride, or hemodialysis.
Okay, question 39. What's the first-line treatment for respiratory alkalosis? You might be tempted to reach for acid infusions, but hold off. The absolute essential step is E, correction of the underlying cause. Respiratory alkalosis happens because alveolar hyperventilation is driving this excessive blowout of carbon dioxide. But remember, this hyperventilation is just a secondary reaction. It's a symptom of a deeper physiological trigger, things like severe pain, raging anxiety, sepsis, or hypoxemia. So, the only true first-line therapy is fixing that root trigger. The exam pearl to lock in here: never use direct chemical interventions or acid infusions for simple respiratory alkalosis. Treat the driver, and I promise you the alkalosis will resolve entirely on its own.
Let's hit question 40. We need to spot a cause of normal anion gap metabolic acidosis. Skip the organic acids and organ failures here. The pathophysiology points straight to E, renal tubular acidosis. So how does a normal anion gap metabolic acidosis even happen? Well, it occurs when bicarbonate is lost from the body, and chloride ions swoop in to replace it just to keep electrical neutrality. Renal tubular acidosis, or RTA, is your textbook cause for this. It comes from a direct defect in the renal tubules. Either they can't secrete hydrogen ions or they fail to reabsorb bicarbonate. For your exams, always contrast this with a high anion gap trajectory. High gaps are driven by a buildup of sneaky, unmeasured organic anions, like lactic acid or ketones, not just a direct loss of bicarbonate.
Diving into question 41. We've got a clinical scenario. A diabetic patient on metformin is heading into surgery, but their arterial pH has crashed to 7.2 and their bicarbonate is sitting at 5. To stabilize them, we need answer A, a 1.5% bicarbonate infusion. Let's do the math real quick. If you calculate the anion gap, 140 minus the sum of 98 and 5, you hit 37. That is massively elevated. In a diabetic taking metformin, this screams life-threatening metformin-associated lactic acidosis. When that systemic pH dips below 7.20 alongside a huge bicarbonate deficit, you absolutely must push an isotonic 1.5% sodium bicarbonate infusion to stabilize cardiac conductivity. And you're critical, never forget it exam pearl, metformin must always be held 48 hours prior to major elective surgery to prevent this exact intraoperative nightmare.
Seamlessly transitioning to question 42. We're looking at massive fluid losses from a high-output pancreatic fistula and need the absolute best replacement fluid. The winner is answer B, bicarbonate infusion with lactated ringer. Here's why: it perfectly mirrors the loss. Active pancreatic juice is incredibly alkaline. We're talking a massive bicarb concentration of around 115 millimoles per liter. So, a high-output fistula drains those alkaline stores fast, leaving the patient in severe hyperchloremic metabolic acidosis. To combat this, you've got to mirror those ongoing losses by giving physiologic electrolytes via Ringer's lactate paired with a targeted sodium bicarbonate infusion. Just remember your GI secretions blueprint. Gastric juices, tons of hydrogen and chloride, zero bicarb. Pancreatic secretions, absolutely loaded with bicarb.
All right, question 43. What is the most important buffer in the extracellular fluid? The heavyweight champion here is A, bicarbonate ions. The carbonic acid bicarbonate buffer system is the main defense mechanism running the show in the extracellular fluid compartment. It manages acute metabolic acid loads beautifully because it has this unique ability to literally convert fixed acids into carbon dioxide and water, which your lungs then rapidly just breathe away. Let's quickly run through the entire systemic buffer hierarchy for the exam. Ready? Bicarbonate rules the extracellular fluid. Hemoglobin buffers the blood. Intracellular structural proteins rule the intracellular fluid. And finally, phosphate and ammonium ions protect the urinary system.
Jumping over to question 44. Which method is not reliable for checking a patient's nutritional status? Don't get distracted by standard metabolic markers. The glaring exception here is answer C, globulin levels. Serum globulin levels are all about immune system activity. They spike with chronic infections or plasma cell disorders. They literally tell you nothing about a patient's underlying nutritional status or their lean body mass. The crucial exam pearl you need to memorize here is about visceral protein half-lives. Albumin is your long-term tracker with a 21-day half-life. Prealbumin, on the other hand, has a super short 2-day half-life, making it your go-to marker for acute, short-term nutritional changes.
Next up, question 45. What's the most likely complication if you completely leave lipids out of total parenteral nutrition? Without these essential fats, you're looking at answer A, skin rash and loss of hair. If you provide TPN that's just dextrose and amino acids, and you skip the lipid emulsions, you are going to trigger essential fatty acid deficiency, or EFAD. The human body simply cannot synthesize essential polyunsaturated fatty acids like linoleic acid on its own. Give it a few weeks and this shows up clinically as dermatitis, alopecia, and really poor wound healing. But hey, don't swing too far the other way either. Administering lipid emulsions too fast can actually cause immune suppression, which seriously bumps up the risk of catheter-related infections.
Let's tackle question 46. What is the most common metabolic complication of TPN in the ICU? The biggest offender, hands down, is E, hyperglycemia. Those highly concentrated dextrose infusions can easily overwhelm the pancreas, outpacing its ability to secrete insulin. This is especially true during severe surgical stress, when counter-regulatory hormones, like cortisol, are surging through the body. Now, listen up, because this is an absolutely critical, mandatory exam pearl. If you have a previously stable patient on TPN and they suddenly develop new-onset, difficult-to-control hyperglycemia, that is literally the earliest clinical warning sign of impending catheter-related line sepsis. You have got to address that immediately.
Moving directly to question 47. Which electrolyte disturbance triggers seizures in TPN patients? The main culprit you're looking for is B, hypocalcemia. Severe hypocalcemia is incredibly dangerous because it drastically increases neuromuscular irritability. It does this by lowering the threshold for axonal depolarization. In the clinic, you'll see this start as circumoral paresthesias, numbness around the mouth, then tetany, laryngospasm, and it can rapidly spiral into full-blown generalized tonic-clonic seizures. And while we're talking about TPN, keep your refeeding syndrome checklist handy. Always watch for hypophosphatemia, which is the classic driver of flaccid paralysis, and hypomagnesemia, which will show up as really dangerous cardiac arrhythmias.
Question 48 brings us a vignette. A patient with recurrent pancreatitis, prolonged ileus, nausea, and orthostatic hypotension. The key lab finding that ties this whole clinical picture together is B, hyponatremia. This scenario is a textbook description of acute adrenal cortical insufficiency, an adrenal crisis triggered by intense metabolic stress. Basically, the acute loss of mineralocorticoids means the kidneys completely stop conserving sodium. This leads to massive volume depletion and hyponatremia, and it's usually hanging out with hyperkalemia and fasting hypoglycemia. To officially verify this diagnosis, you need to document a lack of cortisol response using an ACTH stimulation test.
Finally, we arrive at question 49. What is the most common electrolyte abnormality in acute anuric renal failure following severe dehydration? Because the kidneys can't excrete it, we get answer A, hyperkalemia. Here's the breakdown. Severe dehydration tanks the intravascular volume, leading to profound renal hypoperfusion. Once the kidneys literally stop making urine, they completely lose their main mechanism for dumping potassium. This rapid buildup makes hyperkalemia the absolute most life-threatening abnormality in acute anuric renal failure. So keep this final exam pearl in your back pocket. The full renal failure lab profile typically looks like this: hyperkalemia, hypermagnesemia, hyperphosphatemia, and a steadily worsening high anion gap metabolic acidosis. So the ultimate question is, in a rapidly deteriorating surgical patient, how quickly can you spot this exact laboratory profile before it becomes fatal?